Join the conversation in Tipperary. Contact us through Facebook, Twitter, or email tiptoday@tipfm.com.
Now, Brian was on and he says, Fran, the interpretation of Article 5, the NATO article, is incorrect. It states that other members can react up to and including military intervention. There's no implication that they must or will use military force. Yeah, but it's there as a trigger if you... Forgive the pun. It was established back in 1949, as you know, stipulates that an armed attack against one member is considered as an attack against all, and it commits members, as Brian said there, to collective defence, obligating them to assist the attacked ally with the necessary actions. Now, that's including military force to restore security there. Thanks for that, Brian. 1800 938 007. And you can email us at any time at all. That's tiptoday@tipfm.com. Glad to be joined now by orthopedic consultant at Aut-Even in Kilkenny. Mr. Stuart Edwards is with us. Good morning to you, Stuart.
Morning, Fran. How are you?
I'm very well indeed. Good to talk to you today. I'm just thinking with the changes in the weather out there, it's been extraordinarily wet over the last while. I often hear people speaking about their pain increasing when it's very, very damp and very, very wet. Do you go along with that?
100%, Fran. Absolutely. I mean, we're not quite certain in the orthopedic world why that happens, but it is definitely true. I see it every day of the week, and patients frequently comment on it and state that when they pop over to the Canaries for a bit of winter sun, their pains can dramatically improve. So we think it's something to do with the barometric pressure and how that affects the joint and the pain that you feel from that joint. But absolutely 100%.
Several questions when people knew you were coming on. We got lots of questions into us. Will you ask, Stuart, why does my ACL keep feeling like it's giving way when I twist my knee? Now, just ACL first of all.
Your ACL is your anterior cruciate ligament. Is one of the two ligaments in your knee that stop your lower leg bone, your tibia, moving forward on your femur, your thigh bone. And it's bizarre that they're very specific about is their ACL. So I don't know whether they've had an MRI of their knee, which is and there's a problem with their ACL, but that would be the first thing to do, to get an MRI scan. That would tell you whether your ACL is intact or not. If it's intact, then it may be just a case of building up the muscles, your quadriceps and your hamstrings, which will afford better stability to your knee. And if the ACL is gone and you're young and you're a sportsman, then sometimes an ACL reconstruction is necessary. So the MRI will definitively tell them whether the ACL is intact or not.
Somebody else wondering about a sharp pain behind my kneecap when I go upstairs. Somebody looking for some advice on that.
It's very common for patients with a problem with the kneecap to get issues when they're going up and down stairs or long distance driving, or indeed when they're sat for a long period of time and get up, they can get pain at the front of the knee. And sharp pain normally means that you have some of the cartilage behind the kneecap that lines the joint is reduced, and that can give pain. So it's essentially degeneration or wear and tear. That's the most common cause. If they're younger, it may be they have a bit of instability to the kneecap, where the kneecap is sort of riding to the side, and that can cause pain, in which case physiotherapy can help it. But the best way of really looking at the knee is to get an MRI scan, and that would tell you whether you have any wear and tear underneath the kneecap, and allow us to formulate a treatment plan, which could include physiotherapy, injections, etc.
Somebody else wondering, how do I know if I've got a meniscus tear in my knee? Now, just again, by way of explanation, what exactly is that tear?
Yeah. A meniscus is like a cartilage shock absorber in the knee. It's a C-shaped disc that gives stability to the knee, but also offloads the knee so that you don't have your both bone ends sort of articulating on one another. And the most common symptom with an unstable cartilage or meniscal tear is that you can have locking to the knee, whereby your knee suddenly sticks without you being able to fully straighten it, and you have to bend the knee, sort of wiggle it to get it out straight. So locking is a common symptom with a meniscal tear. You can also have pain. Nearly always it's the cartilage on the inside of the knee that tears, and the pain you feel is normally at the back inside part of the knee, and you can get clicking as well. And when you force the knee into a full extension or fully straighten the knee, that can cause pain, or even when you squat, it can catch that cartilage tear or meniscal tear. So that's the most common symptom, but the best way, again, of diagnosing it is to get an MRI scan, and that's the most definitive test to tell you whether you have a meniscal tear or not.
I'm just wondering why the listener is asking that. Is it because the symptoms could reflect something else?
It could. I mean, if you have wear and tear in your knee, on the inside part of the knee, that can give you symptoms that closely resemble having a cartilage or meniscal tear. And frequently, patients have a bit of both. And that's when, you need to be a bit of a detective and try and establish what's causing the worst pain. But on the whole, if you have wear and tear in the knee or arthritis with a cartilage tear, the arthritis trumps the cartilage tear. And there's very good evidence in the literature now that keyhole surgery for knees that have a bit of arthritis and a cartilage tear don't normally work very well, because you're not getting rid of the arthritis, and that's the most dominant problem, and that trumps the cartilage tear. So you need to be careful doing keyhole surgery, sometimes unnecessarily, in patients that don't have any true mechanical or locking symptoms, and if they have arthritis in the knee as well.
Pat was on. He says, will you ask Mr. Edwards how long does a hip last? So I presume he's talking about a hip replacement. And how do you know when it needs to be replaced again? My hip is now about 18 years done at this point.
Well, that's phenomenal anyway, to start with.
Is it?
Yeah, absolutely. We can't. It's not a hip replacement. Not a lifetime operation on the whole. Now, that's not to say that patients haven't had hips that have been in for 30 years or more. It's very variable and depends a lot on when it was inserted. So if it's in your 50s, then the physical demands upon that hip replacement and the cycles that you walk will cause it to wear out sooner than perhaps if you had it when you were 70. So we believe now if you're 70 and you have a hip replacement, on the whole, it might last your lifetime. But patients in their 50s is unlikely to last their lifetime. So as a general rule, we say 15 to 20 years on the whole. Now, the symptoms you'll get if the hip is starting to fail is you get similar symptoms to the pain you had before you had the hip replaced. So pain in the groin and pain that runs down the front of the thigh, and pain when you first get up, which is called start-up pain. Those are the most common symptoms saying the hip might be starting to wear out.
But I presume that the materials have changed over the years. Like he's hip, 18 years old. That would have been different materials, would it? Yeah,
absolutely. Yeah. Particularly the liner that goes inside the socket that goes in your pelvis. The liner that goes in there now is made of a very highly cross-linked plastic, polyethylene, which has better wear characteristics. And those have been used probably for now the last 12, 15 years. And all the signs is that plastic wears a lot better than the previous plastic we used. And we're very hopeful that might mean that the implants will last a lot longer. But the jury's out still, because we haven't got time on our side. We haven't got the history there and the evidence to say that, but we believe that's the case.
A final one for me, if you would, Stuart. Could you ask the consultant, how should I deal with swelling to the front of my knee after I play a GAA game? Well, I suppose it doesn't matter what sport, but the front of the knee swelling there?
Yeah, there's two aspects of swelling associated with the knee. One is swelling within the knee that's sometimes appreciated as being swelling in front of the knee, or they're swelling truly in front of the knee, which is not in the knee joint. And that's called your pre-patellar bursa, which is a sac of fluid in front of your kneecap. That frequently gets swollen in tilers and carpenters and people kneeling all the time. So that's very distinct from swelling that comes from within the knee, which I suspect is with this listener. And if you get swelling after playing sports, it's down to the old adage of rest, ice, compression, elevation, and maybe an anti-inflammatory if you can tolerate it, and that should help reduce the swelling. But if it persists, you need to get it investigated because you need to find out why you're getting the swelling. Is it an inflammatory issue, or have you got some wear and tear in the knee that's causing it to flare up? So if it's persistent swelling after activities, then get an MRI scan.
Just about out of time, but I'm very curious about this one just straight away in from a listener. Having got 2 platelet-rich plasma injections for lateral ligament tears, there's a mouthful, do I still need to do knee exercises to build up the muscle, as I find it hurts when I do?
It's very important to build up the muscles. Seek a good chartered physiotherapist because they'll show you the right way and the correct way of doing it. If you're doing it slightly wrong, it can cause more pain.
What are those injections, Stuart, the plasma injections?
So enriched platelet injections, or PRP injections, that's where you take blood from the patient, you spin it in a machine in a centrifuge, and that layers up the components of the blood, and there's a particular aspect of the blood which is enriched in platelets, and we then inject those into the joint or into ligaments, and that's like the body's own natural growth factors and anti-inflammatory factors that can help heal ligament sprains and can help reduce pain from the joint. So they're quite commonly used now for joint problems with wear and tear or ligament issues.
Fascinating. Thank you so much for your time this morning, Stuart. Thank you, and good
my
morning
pleasure,
to you.
Fran.
Thank you.
Take care.
Bye-bye
Thank
to you
you.
now. That is our orthopedic consultant at Aut-Even in Kilkenny, Mr. Stuart Edwards. And apologies, we didn't get to all of the queries today, but we will hang on to them for next time round. We are live from Nina. News and information is coming up.
Tip FM's Tip Today.
With Slattery's Garage, puck on. It's time to change. Test drive the award-winning range of Peugeot hybrids and fully electric vehicles at Slattery's Garage today. See slatterysgarage.ie.